I would like to invite Dr. Starke from the third-party opposition and the Minister to speak. Dr. Starke, are you wanting to combine your time with the Minister?
If that's acceptable to the Minister, yes, please.
Yes, please.
Go ahead.
Well, thank you, Chair, and thank you, Minister, and to all the members of the Health Ministry team that are here tonight. I want to thank you for being here. And I also want you to know that Albertans are very appreciative of the work that they receive from our healthcare system. Health and universal health care, in my view, are fundamentally Canadian values that date back, basically to the 1960s. Now, some of you will remember that there was a survey back in 2004 by the CBC on the greatest Canadians of all time. And we can, like all lists, we can debate all kinds of reasons why people should or shouldn't be on those lists, but it should be noted that Tommy Douglas was voted #1 by Canadians. And I would suggest that that ranking reflects not only an admiration for Mr. Douglas, but a strong belief in Canadian Medicare. So that said, Chair, Medicare and indeed our healthcare system at writ large is not a sacred cow. We must be prepared to examine all aspects critically. I am some familiarity with examining cows, and be prepared to adjust with the times. And so my questions both tonight and tomorrow are intended to try to help find those cost savings, which I would argue we must find in order to protect both the universality and the quality of our health care. So, Minister, I'm going to shift gears a little bit. I know we've been talking largely about operational expenses, but I want to talk about the health department's capital plan. So if I could ask you to take a look at page 46 in the fiscal plan document, in which the 4-year capital plan is outlined for your department. I'm going to start with a question I've asked other ministers as well, and curiously I'm getting different answers from different ministries, and that is, why have we shifted from a 5-year time horizon to a 4-year time horizon on the capital plan?
I'm just trying to Google how many stomachs a cow has, because definitely, I thought it was 4. I was questioning myself there. Definitely, I'll tell you when I came into this role and saw some of the areas of growth moving the fastest. They were physician compensation, hospitals, and pharmaceuticals, and I felt like those stomachs were doing more than their fair share some years. So I just wanted to start by saying thank you for your analogy. In terms of the 3-year versus, or the 4-year versus the 5-year, I think that there are some questions that are still to be considered about what is going, some of the funding models that might be moving forward. So I think there's some policy decisions that might have to be made. We are in the 2nd year of the 5-year plan as well, so that would mean that it would end in year 4. So because last year was the 1st year of our 5-year plan.
And that's somewhat similar to a response I got from another minister. I guess what I would just say is I would really encourage you to continue a program of 4 or 5, land on 1, planning for capital. I know that that's very common in municipalities. In fact, they quite often have 10-year capital plans. I think that's helpful in terms of giving some indication of a direction for what is being planned. But in looking at these documents, Minister, the comparison of this year's 4-year capital plan to last year's 5-year capital plan, this year's capital plan is actually over $1 billion additional, more than last year's capital plan. It's like a 29% increase. And that's pretty significant, especially when we're considering a shorter time frame. So I guess my question to you would be, what's the anticipated impact of adding an additional 29% of capital spending to the operational budget of the department?
Yeah, well, and thank you very much for the question. Some of the capital spending is about replacing outdated deferred maintenance, obviously areas that have been neglected for a significant period of time. And regularly in the House, I hear about more areas that we haven't even been able to fund with this increased allocation. Some of it is about making sure that we bring projects online, like the needed Calgary Cancer Hospital, which definitely will have some increased capacity, but is more than needed. And for example, right now, because of the physical limitations in the space, staff have regularly expanded the hours to include evenings and weekends. weekends because there are just too many patients for the space that's available. So some of that service that's being done in those exceptional hours would be moved to more traditional hours for the patients and for the families. So rather than having to have your chemotherapy at 9 p.m., you would be able to go during the day. So I think that some of that will be shifted in those ways. But there are some areas where we're going to certainly see some increased costs, and it's because there's increased need in those healthcare areas. So Grand Prairie Hospital, for example, being one.
So just on that note, though, the capacity issues, I guess what I'm wondering is for some of the capacity issues, first of all, I'm asking whether those are occurring primarily in urban hospitals or is it widespread across the province? And the second question I would have is that during the course of the rural health study, we found that there's quite a bit of underutilized capacity in rural hospitals that are in fairly close proximity to urban areas. And I'm wondering what has been done or what initiatives have been pursued in terms of making better use of existing infrastructure in rural hospitals that may, take some of the stress off urban hospitals.
Yeah, and I think a great example of that was when in Red Deer we had a flood in some of the operating rooms, and a lot of those surgeries were moved to Stettler, Consort. Definitely a bit of a drive that people from Stettler are used to doing into Red Deer, but not necessarily the other way around.
Same distance.
But it is the same distance, yeah. So definitely the patients who were in need of those treatments appreciated community stepping up and increasing access, and so did the people in Red Deer, who of course were working to get those spaces back online as quickly as possible. In terms of the spread of some of the investment, as you asked about, through some of the other areas, for example, the Edson Healthcare Centre in this year's budget, we've recently opened it, but we have $14 million in this upcoming budget that needs to be added to that. Fort McMurray Resident Care Centre, $43 million. Grand Prairie, $353.
Actually, Minister, I have the list in front of me here.
Okay, so that was just my way of responding to the question around the cost.
And I appreciate that. I guess parenthetically, I'll also mention that, and I hope, Chair, that this isn't getting too far down a rabbit hole, but I know that one of the concerns was expressed to me by some of our physicians that practice in Vermilion, and that is that currently the therapeutic guideline for a positive fit test is to have a colonoscopy done within 3 months. Right now, the wait list, or the wait time, at least in Edmonton, is some 8 months, which is outside of clinical guidelines. But if folks are prepared to make a drive out to Vermilion, we'll scope your colon in 6 weeks. And the good thing is you can park for free and close to the door, which after 24 hours ago, lightly, you want to be really close to the door. So just a possible suggestion. That's something that the doctors actually suggested to me, so I'll pass that on to you.
No, that's great. And we do have a project that's underway now where Hinton is receiving colonoscopy patients, for example, as well. So that's something that I regularly encourage people to say to their health practitioner, that they're willing to travel a little bit further if it gets them in faster. Great.
I think that's very helpful. So back to our capital list. So if we look at 2017 versus 2016, there were 30 projects on last year's list. 5 of those projects have dropped off, and I'm going to assume because they've been completed. Although in one case I was a little bit curious. Red Deer Obstetrical, which was on last year's list, is now completely off. Now, has that been fully funded already? I know the announcement was made.
Yeah, it opened. Actually, we had the official opening today.
Okay, so great. That's fantastic. I congratulate you on doing that. And the other 4 projects are ones that you'd be familiar with. But we've also added 8 new projects. And those 8 new projects carry a forecast cost of $1.2 billion for the next 4 years. So, Minister, how many of those new projects were on the unfunded project list last year?
The list formerly known as the Sunshine List.
Sure.
Yeah, I think that was the list. So while my officials flip to those appropriate pages for me, I'll say that the unfunded list is certainly, and my time in the school board, I came to know this too, is that that sometimes based on pressures and demands, either by the state of a building that might be unsafe for future use, or by massive increases in population or demands, sometimes those lists do need to change, but they're definitely there for a guide, and I think that list, as we present it outward, is, assuming all conditions stay standard, we would like to see those projects move forward as quickly as possible. So they are just looking for the page, but we haven't found it quite yet. We'll try to get it in the next couple of minutes. comments.
Sure. Well, I've taken a look at it, Minister, from my looking at it, and I could be wrong, stand to be corrected here, but of the projects that were on the unfunded list, you had 6 projects on the unfunded list last year. One of them, the Norwood Long-Term Care Facility, was moved from unfunded to funded. And I actually want to say to you and to your Finance Minister, thank you for doing an unfunded projects list. I think that's very helpful. But of the 6 projects that were unfunded last year, 3 are still on the unfunded list, so that's the inpatient unit fit-outs at the Chinook Regional in Lethbridge, the medical device reprocessing upgrade, which was renamed to Provincial Sterile Instrument Reprocessing Upgrade, and the Peter Lougheed Centre Emergency Department and Laboratory. So those 3 projects are still on the unfunded list.
Yeah.
But 2 of the unfunded projects have disappeared entirely. One being the A.R. Schreg renovations at the Alberta Hospital in Edmonton, and the second, the Cross Cancer Institute Phase 1 in Edmonton as well. Are they still on the department's radar? Is there any reason, should we be concerned that they've dropped off the unfunded list? Does that mean that they are now at a lower priority level, or what's the status on those projects?
Yeah, so I'll provide a little bit of rationale for both of them, and thank you. Your analysis appears to be consistent with the analysis of the folks here at the table. So in terms of the Schreg renovations at Alberta Hospital, the Child and Adolescent Mental Health Bed Project was considered a higher priority by AHS in this year's submission. So it's still something that is on the awareness, but we did move forward with that project at the Royal Alex this year, and consistent with the AHS submission that was amended. And in terms of the Cross, the project was lowered on the priority list due to other operational and system pressures with regard to reevaluation of Edmonton service plan that is underway. So if AHS wants to make sure that expanded cancer care, that they've considered the variety of projects that will be available, including the new Edmonton Hospital, when they're trying to decide where to align some of these resources in the next year. But I expect that we'll continue to see investments in mental health for youth, as well as Cross Cancer Institute, or other cancer care.
Yeah, on that topic, Minister, one thing I was just going to mention is that you had mentioned a little bit earlier about expansion of services for mental illness and addictions treatment, and especially with our opioid crisis that we're dealing with. Just as an aside, the Thorpe Recovery Centre, which was opened in Lloydminster in 2012, with a lot of Alberta government funding involved with it, is presently operating at less than capacity, and we have 4 Alberta government funded beds. There are a number of empty beds in that facility that would be ready, and there would be no additional capital expenditure. The staff is there, and so if that's something to that you and the Associate Minister may want to take a look at, we certainly encourage you to do so.
Thank you.
I want to have a little closer look, drill down at the 8 facilities that jumped up onto the funded list. I'm not going to quibble with the facilities. I think for the most part, these are all worthy, sort of things to have on a wish list. I note that most of them are very heavily backloaded in the out years of the funding, that there's very little funding for the next couple of years, but a lot of funding for the last 2 years. And depending on how construction and planning goes, we may achieve that and we may not. But one that jumped out at me was Provincial Pharmacy Central Drug Production and Distribution Centre. Are we in the business of making drugs now?
One of my colleagues asked a very similar question at Treasury Board. This is more around aligning and packaging, and then later distributing these drugs, but it is around consolidating them, I believe. But I'll ask my deputy to expand on that a little further.
There are an increasing number of pharmaceutical compounds that need to be created right away, that they're mixtures, they don't come pre-made, pre-packaged. And we have a number of pharmacy facilities in some of our hospitals that are struggling to maintain accreditation. So the idea is to aggregate these into 2 large hubs for the major urban areas. We don't make the drugs, but sometimes you have to mix things together to make the drug that is then administered. This is particularly the case in medical assistance in dying, for example. The other area where we are struggling to maintain accreditation is that some of the more modern pharmacy dispensing equipment is large and digitally controlled, and we simply cannot fit it into the spaces that are still available in some of our older facilities. So we're not getting into the manufacturing business, but maybe call it partial assembly.
But you are compounding. You are compounding, and there is a whole slew of regulations and requirements for compounding because, I mean, they apply also to the veterinary profession.
Yes.
And I would caution the government that this is something that you want to proceed with a great deal of caution, and that you should have a long discussion with the RXA, with the pharmacists, before proceeding down this road. Getting into the compounding business or the compounding job, and I know it happens in hospitals, but getting into a larger scale, I just urge caution on this, because there are private companies that are doing this already. They have the accreditation, they have the staff that are already providing that particular function. We've got $40 million allocated for the capital side of this, so I'm taking it's a new facility, and that's a significant investment, and I didn't recall any conversation about us, but we as a province are getting involved in this activity. So I think it is something that should be raised with the general public before we go down this road.
It's not a massive expansion of what we're already doing. It's handled by AHS in conversations with the pharmacy regulators, and the pharmacy associations.
Okay. Well, we'll leave that one for this right now. Minister, last year we had a discussion about primary care networks, and primary care networks, as you know, when they work ideally, provide team-based, multidisciplinary care to hopefully provide a lot of preventive care and keep people out of the hospital as opposed to dealing with them after they've become ill. And it's also critically important for the management of chronic and long-term disease situations and patients that are coping with those. I'm unable to find it, though, in the budget what the estimated expenditure on PCNs is for the coming year and how it compares to 2016-17.
Yeah, and I have that here.
Great. Am I missing it, or is it a specific line item, or is it?
I think it listed here in this description.
Embedded.
The government aims to have 80, this is about the business plan. Sorry, this isn't in the estimates. It may be under community-based care. So I'll have my team flip through to find the right page. Oh, here we go. It's under primary health care, item 6.2. Funding in that line item is to support the PCNs, the structure which allows the physicians, as you said, to work in collaboration with AHS and other healthcare providers to harness the collective strengths of members of the team to work together in that area. So it's a 20, last year we saw, that change is it 41%? 41% from 60 million last year to, 60 billion? 60 million.
60 million,
Sorry,
please.
60 million to 71.78, and it's because we had, last year we accessed some of the reserves that were set aside.
Okay.
So this year we don't have those reserves to.
Sorry, Minister, you're
access.
saying line item 6.2, primary health care?
Yeah.
So that it's embedded within that number, I take it? Because the number I've got in 6.2 is, for this year, at least 244 million.
So can you explain, if you don't mind, Charlene, what the yellow shaded number is indeed? So this is Charlene Wong, acting ADM.
Thank you.
Yeah. Sorry, I don't have the exact number for PCNs. I can pull that out for you for tomorrow. But the numbers the minister was referring to, the 60 and 71, are the changes from the budget to the forecast to the estimate, not the total allocation. So just to clarify that, but I will get that number for you.
Okay. Well, thanks. Minister, as you know, there's been a fair bit of discussion about the functioning of PCNs since they were instituted a few years back. And, I think that most Albertans share the concern about the variability with which they provide service. Some PCNs are doing a fabulous job. Some PCNs, it's a little bit questionable. And I guess the real question is accountability back to the taxpayer, because on the capitation formula, they're providing services. The $62 per patient rostered is going to the PCN, but we don't necessarily get a lot of feedback. What measures are being looked at in order to improve the measurement and the metrics and the accountability for PCNs in the province?
Yeah, so I'll start and then again welcome my deputy to supplement. One of the first things we did was launch a financial review, and you're right, not only do the level of services vary across the province, the level of head nodding expenditures varies as well throughout the province. So we worked to ensure that we were very clear that things like buying presents for the staff are not appropriate expenditures for money that's supposed to be supplementary to these health expenditures. Buying alcohol for your Christmas party, not appropriate expenditures for these $62 per patient per year that are intended for these services. So part of it was beginning to look at how money was currently being used, and of course as we work as we move forward. And I have to really commend the PCN leads on being partners and stepping up to the table with us. I know it's not easy to give money back that's been in reserve, but they know that equity was not alive and well under the former model, and they want to work with us as partners in developing the new model. So they're at the table, and we are doing a review of the funding model as we speak. Sorry.
Thank you. I would now like to invite Dr. Starke from the third party opposition and the minister to speak. Dr. Starke, did you want to go back and forth with the minister?
Yes, please.
Go ahead.
Well, thank you, Minister. For this section, I'd like to concentrate on the operational side of things. We talked a fair bit about capital.
Yep.
As you are extremely familiar with, the three main cost drivers in your department are physicians, hospitals, and drugs. And of course, that is the same challenge that is shared by your colleagues right across Canada. And I'm looking actually right now at a chart that was produced by Canadian Institute for Health Information for 2014. And I'm sure there's been a more updated one, but it shows per capita health spending in basically 6 of the largest provinces. It doesn't include the maritime provinces. And I'm sure you're very familiar with the numbers, but I am concerned, Minister, that when I look at this year's estimates, for example, the section item 4 on page 152 of the budget, or of the main estimates, shows an increase of some 9.86% in drugs over last year's budget. The increase on physicians is 7.08%. And I'm having a little bit of difficulty finding out which line item in the budget would be the most apropos for comparing to the price or the budgetary expense for hospitals. But in any case, Alberta has the dubious honor of being number 1 in per capita expenditures on physicians, number 1 in per capita expenditures on hospitals, and number 3 in per capita expenditures on drugs of those 6 provinces. So I'm just wondering, let's maybe start with drugs first. What specific measures are you taking in this year's budget to try to bend that cost curve, which I know is very challenging as generic and less expensive pharmaceuticals are being replaced by ever more increasingly expensive pharmaceuticals that may well have therapeutic efficacy but are also very expensive?
Thank you very much for that. There are some things that your caucus says you're welcome for. I'm assuming this is not one of them, because there's still a lot of work that needs to be done in this area. I'm going to touch a little bit on drugs first, as that was your main focus, and saying that there are a number of drugs that are continuing to come online that are costly upfront, but have significant savings down road. So, for example, there's new hepatitis medications that are coming online this year that can actually cure hepatitis. Types that before would be chronic conditions for patients for years. So arguably, this upfront cost that we see for 1 or 2 years in the medication could save significantly on the acute care pressures that the hospitals are facing, but those are significant costs for those drugs in the first place. Some of the work that we're doing with the Pan-Canadian Pharmaceutical Alliance is around the prices for 113 brand and generic drugs have already been reduced. So that is because we're working collaboratively with these other provinces that, like you said, are seeing similar pressures. And there was an estimated savings of $712 million annually in the last few years since we've been able to get, last year since we've been able to get these 113 on. That is not driving the total cost down, though, because new drugs continue to come online. People are living longer and are having more complex care later in life as well.
Sorry, Minister, excuse me, that $700 million, that's Canada-wide?
No, I believe that was our, well, oh, it was Canada-wide. Sorry. Oh, Alberta saved more than $100 million over the last 3 years, so that's our share of the $700 million.
And
so that's good.
Nothing to sneeze at.
Thank you. Yeah, and as of April of 2016, the Pan-Canadian Pharmaceutical Alliance, the prices of those, that's doubled up there. That was the change that we were
Okay.
referring to. And the prices of 18 generic drugs have been reduced to 18% of the brand name prices.
Right. So Minister, last year we had the discussion. I'm just wondering what the follow-up has been in terms of sitting down with the prescribing physicians, obviously, but also the pharmacies that fill a lot of these prescriptions, because pharmacists have a number of ideas, including therapeutic substitution and the increased use, especially when somebody is starting a medication for the first time, of using a trial prescription that is relatively short, let's say a week to 10 days, during which time a patient's tolerance for a drug can be determined. What is happening, and this is maybe a little bit getting into details, but what is happening currently is that somebody will come in with a new prescription on a new medication. They might get 3 months worth, find out that they don't tolerate that prescription really well, and 2.5 months worth of the prescription ends up getting pitched because it can't be reused, obviously. So I'm just wondering if those or other means that the pharmacy profession have suggested, whether those have been looked into in terms of trying to reduce that overall pressure on the drug cost.
Yeah, that's a great point, and something that I think would probably need to be looked at with the patient's condition, as well as access to pharmacy as one of the guiding principles there. There are some communities where there isn't a pharmacy, so you wouldn't want to have somebody drive another hour 8 days later, but I think that there are many instances where that could possibly be the situation. One of the examples that I'll touch on is around with biologics, which are incredibly expensive, and biosimilars coming on. They're asking physicians to prescribe the biosimilars first, see if they work, and try those rather than going to the most prohibitive or most expensive version. But we do have the executive director for pharmacy here, our drug guy. If you'd like to hear from Chad, I'd be happy to call on him.
Sure, just really briefly, we're limited in time, but give us your best 90-second précis on how we can save a few $100 million on drugs.
And say your name and title, please.
Good evening, I'm Chad Mitchell. I'm the Executive Director for the Pharmaceutical and Health Benefits Branch at Alberta Health. We've worked with the Pharmacy Association of Pharmacists on expanding their scope of practice,
Right.
but also remuneration for cognitive services,
Right.
we call pharmacy services.
Yeah, no, familiar with that.
And this allows pharmacists to do patient assessments, especially on the complex ones,
Yep.
and create care plans for their care.
All fantastic. I'm just wondering, if there's additional work being done in terms of expanding the use of generics, in terms of therapeutic substitution, especially therapeutic substitution. It's something that's already being done in hospitals, and it would result in a huge cost saving in terms of reducing the use of brand name drugs, the newer drugs that sometimes in terms of therapeutic efficacy are not specifically better than a drug that's been around for 15 or 20 years.
We have launched a couple initiatives, one being the proton pump inhibitors review. So the
Right.
Minister has an expert committee on drug evaluation of therapeutic
Right.
that can take a look at the best practices out in the community, and we can work with our pharmacy association, our college, to make sure that the pharmacists have the right support. So that is an area that we are focusing on in the coming year, sitting down with their association and the college to make sure that we have the right support in place for the pharmacists.
Well, while you're there, I'll just ask maybe one more question, Chair, that is drug-related, and that is we've had a number of discussions in the past with regards to the Rapid Eye program. I'm just wondering, now that it has been operational for roughly a year, where are we at? What is the estimated savings? Are we hitting those 80-20 mandated targets amongst the ophthalmologists for treating of macular degeneration and some of the other conditions?
If the program has been successful, we are achieving those targets of the 80-20 split between the brand name innovator product and the additional product we added on. We are taking steps to add another choice.
EYLEA?
Correct.
Yeah.
To access for the clinicians that are having those injections.
Okay.
So overall, we've reduced on our budget approximately $50 million as a result of this Rapid Eye program. And that's reflected in the budget estimates.
Okay. Good. Thank you very, very much. So finally, Minister, just in the last minute and a half, we had quite a bit of discussion in the first segment about physician compensation. And I want to say, and I've said this before, that I applaud both you and the AMA for the efforts you've made. I think we have to keep working on this. This is not a closed book by any means. I'm a little bit concerned about differing numbers that are getting tossed around for fee-for-service. Certainly when we did the rural health review, the predominance of fee-for-service compensation amongst our physicians is problematic. It leads to turf protection and also leads to patient hoarding, almost to the point in some communities. It's not good for the community or the patients. And I'm just wondering, the number that I have is 87% of our physicians are compensated primarily on a fee-for-service basis. It's the highest of any province. What specific methods are being used, and maybe Dr. Amram can help with this, in terms of reducing that number? How amenable is the AMA to? Because as I understand it, younger medical graduates are more interested in working through alternative remuneration programs.
Yeah, I'll start, and then I'll ask Dr. Amrine to add if he'd like to. Definitely, this has been an item of discussion at the AMA, I think, for a number of years, and definitely is something of interest. We have welcomed clinics where all of the physicians are interested in moving.
Thank you. I would now like to invite Dr. Starke from the third-party opposition and the ministers to speak for the next 10 minutes. Dr. Starke, are you wanting to combine your time?
Yes, please.
Go ahead.
Well, thank you, Chair. Thank you again, Minister, and to staff, and Associate Minister, welcome. You missed a riveting session last night, but we'll try to match it today. Minister, I have a number of questions flowing out of the business plan that deal to a large extent about performance measures and monitoring of the overall performance of the system. But I'd like to start by asking, we acknowledge the desire and the need to improve the quality of our healthcare system, but I'm curious to know why the government's discontinuing the Health Quality Council of Alberta, the biennial survey that is being done. Why is that being discontinued?
Thank you very much for the question, and I look forward to you telling us more about Tommy Douglas in subsequent opportunities, I hope.
I could give the cream separator story, but it's a long one, and I only have 10 minutes.
You got 10. With regard to the question of the biannual survey, I believe that this was something HQCA submits their proposed business plan to us every year, and I believe that they wanted to focus some energies in other areas. I'll confirm that, but that's my recollection. The response rate without landlines is problematic. We're aware, I'm sure for all of us who've tried to do outreach to a number of individuals, it's more complicated now than it was 30 years ago. So I think that was one of the pieces, but I will confirm that it was the HQCA. If it was not, I'll be sure to follow up in written response.
Sure. Okay. Thank you for that. Minister, I want to just go back a little bit. I was looking through the 2016 business plan outcomes and targets, and I recognize we're looking at the 2017 budget, but there were some things in the 2016 budget that are now not there in 2017. And so I guess I am interested to see what the performance and some of these key strategies were. So just as an example, key strategy 1.2 in 2016 was to create 2,000 public long-term care and dementia spaces over 4 years. I'm just wondering how many spaces were created in this past year, and how many do you anticipate to produce in the coming year?
Yeah, thank you very much for the question. And we did reword and so there was some rewording, as you've rightfully noted. The key strategy on adding the 2,000 continuing care beds has been amended slightly to include dementia beds as well. We've definitely heard from folks in the community, so those won't all be public long-term care beds. Many will have to be at DSL level 4D beds. But as a number of projects are continuing to move forward, and as we announced in the most recent budget, the 550 new spaces in this year's budget. Last year, there were a number of projects that were through ASLI, where we were able to successfully upgrade the beds from lower levels, as were announced previously, to dementia beds and to long-term care beds. So some of those that will open this year include Calgary, Medicine Hat, Red Deer, Edmonton, Hythe, and the lovely community.
44 beds in Lloydminster, and I want to thank the Minister for that. We're anticipating that expansion to our services very much. Minister, on the same light, Strategy 1.3 in 2016 talks about to implement the addiction and mental health strategy. I know that was the Valuing Mental Health work that was chaired by Dr. Swan and was I think, another good blueprint for the implementation of improved mental health care for Albertans. So we know where the strategy is. We know how Albertans can see the strategy. I guess, what is the progress being made? I know there were 5 high priority items that were initially implemented, and then there were a number of other recommendations. I'm sure Dr. Swan could tell me the exact number, but there were a number of other recommendations that were sort of in the hopper, and we were going to get around to them as well. Where are we at with that?
Thank you for the question. So as you rightly noted, the last year's budget included progress on a number of the recommendations coming from the Valuing Mental Health report. And from there, a big piece of the work that's been ongoing in that time has been around basically just fleshing out the implementation plan, as well as bringing together not just officials from within Alberta Health and Alberta Health Services, but indeed across government and community groups, to ensure that we have kind of a better sense of the work that's being done across the province around mental health. And so we continue to move forward on that in the coming year, and have set forward quite sorry, the exact number is escaping my brain right now, but we've got several $1 million allocated in this year to continue with the recommendations along that line. Additionally, one of the pieces was around opening some youth detox beds in Red Deer, and I'm pleased to say that the tender for that has gone out, and we expect to be moving forward with that project shortly.
Okay. Well, thank you for that. And I'll also mention, as I did to the Minister last night, as far as youth detox and adult detox beds for that matter, there's a facility in Lloydminster that actually was built largely with Alberta government capital funding that is underutilized currently and has vacant beds, and so certainly could be used. Moving along, 2016 in outcome number 2 of the business plan, key strategy 2.3 at that time was, and I quote, to develop a whole of government approach to wellness and collaborate with key partners to build community capacity in support of wellness. Now, that I cannot find in this year's business plan, so I'm taking then that indeed you have developed a strategy, and so I'm curious, what is the approach that was developed, and how is this working across government?
Thank you very much for the question and the opportunity to elaborate a little bit on that. We definitely held consultations in 120 communities and AHS with community and AHS health professionals. That was, 120 participants, not communities, I believe. And we're working with them in an advisory process to make sure that we identify the best way to implement that in partnership with AHS. But we are continuing to work on this initiative. It just hasn't been identified as one of the measures in this year's business plan.
So it is ongoing, though?
It is ongoing,
okay.
Yeah.
Okay. Well, I would certainly encourage that. I think that's a positive thing. I mean, I absolutely concur with the statements Dr. Swan made last night about additional resources and additional emphasis placed on preventive health care and primary care and access to primary care, not just through primary care networks, but primary care professionals, whether they be nurse practitioners or LPNs or, by whatever means to develop a team-based system. Key strategy 2.7 in the 2016 business plan was to implement a wait time measurement and wait list management policy to address long wait times in the healthcare system. Now, that's also absent in this year's business plan. So again, I'm curious what measurements and policies have been developed, what are the metrics, and how are things going? Are we seeing improvements? Are we seeing some measures improve and some measures maybe deteriorate a little bit? I know Kai does reports on these on a regular basis as well.
They do, and I'll start by saying some of the areas where we've seen improvement, because I think that's...
Start with the good.
There we go, thanks. So hip fracture repair rates, radiation therapy, stroke treatment centers, these are definitely areas where we've been able to see address success in terms of reducing wait times. There aren't enough areas. We certainly have far further to go, and we know that all Albertans deserve the fastest response times we can possibly do within the resources that we have. A few other areas where we've made improvements: 25% decrease in wait times for neurosurgery between the 2015 dates and present, as well decreased wait times from specialist to treatment in a number of areas, 20% for general surgery, 21% for internal medicine, 14% for specialists focusing on ears, necks, and throats, a number of areas. One of the areas where we're struggling the most right now is around cataract surgery wait times. That is an area that we have far more to do as the population continues to grow and the number of people in need of cataract eye surgery continues to increase.
Yeah. That's interesting because I had cataract surgery February a year ago here at the Royal Alec, and I don't know, I think I waited 6 months. I could see, so it wasn't a real urgent issue, but the care was excellent, I will say that. Finally, Minister, are we measuring the delay or the wait time? One area that I hear a lot from constituents on is the wait time from seeing their GP to seeing the specialist. A referral is made, but there seems to be, in some cases, an inordinately long wait to see a specific specialist. And in some areas, I think of a special concern are psychiatry, and where there seems to be a shortage, as well as some of the more specialized areas that where wait can be a real critical problem. Certainly oncology is one area that, if we have a wait that's inordinately long, obviously the condition can progress.
These are absolutely some of the priority areas that we're looking at. And I think that there can be a few different ways. You shared a personal health story, so I'll share one too.
You've got 7 seconds.
Oh. In terms of enabling patients to be partners in their health care, having an electronic health record will help with that.
Thank you. I would now like to invite Dr. Starke from the third party opposition and the minister to speak for the next 10 minutes. Dr. Starke, are you wanting to combine your time with the minister?
If possible, yes, that'd be great. Thanks, Chair, and thank you once again. I'm going to return to the topic that we left off with, and that's Key Strategy 2.3 on page 82 of the business plan, and that's maternal, infant, and child health, and by supporting initiatives that foster maternal, infant health, and early childhood development. Critically important work, and I mean, if there was ever an area where I think there could be huge payoffs in the long term, not just monetary payoffs, but payoff in terms of an overall improvement of the health of our society, I think that certainly is in this area. I guess I'm wondering what specific initiatives have been supported by the government. Are there some examples that you could give? And I have one example. I'm curious to know whether it has been supported as well. So you go ahead first.
Yeah, so the work around the maternal and infant health strategy is ongoing work of the government and of Alberta Health. And as I mentioned in response to an earlier question, we're also doing work with First Nations, Inuit, and Métis communities around targeting particularly the outcomes for Indigenous mothers and their babies. And so that's an example of a particular one. As well as, a key piece, of course, is ensuring that there is access to prenatal care available to all expectant mothers in Alberta. And certainly there are some challenges that arise with that, particularly for vulnerable populations.
No.
Additionally, there are fetal alcohol spectrum disorder related grants available across the province in an attempt to reduce the number of infants that suffer from that condition.
No, that's great, and I'm glad to hear those things are ongoing. I guess one question I would have is that we have actually a world-class initiative, the Alberta Family Wellness Initiative, that's undertaken by the Palix Foundation. I'm just wondering, is there support from Alberta Health? Is there any sort of coordinated working together with Alberta Health, with the Alberta Family Wellness Initiative? In my view, the work that they have done is absolutely could hold the key to a lot of issues, including the addictions issues that we've discussed quite a bit, because a lot of the bases for the addictions that we're struggling with are, in fact, that groundwork is laid through adverse childhood events that are tracked through some of the work that's been done by the Alberta Family Wellness Initiative.
Yeah, absolutely. And your comment about adverse childhood events is really a key one. That really the level to which that factors into social determinants of health is a really important one. And there is research work and research funding that we've allocated for that. There's a lot of really fascinating research going on right now that can have, I think, a really huge impact on outcomes in the long range. One of the interesting findings that was through a partnership with the research. There's a research chair that's I believe co-hosted between University of Alberta and University of Calgary, particularly around maternal health and perinatal mental health. Particularly, was findings that for expectant moms with untreated prenatal depression, that the impacts for those children extends well into their childhood, and the number of youth that are having mental health.
You're quite right, and I mean some similar findings, for example, on premature births and that sort of thing. So I want to completely now shift gears for the remainder of this segment and talk a little bit about the Rural Health Review. Minister, you and I have had many conversations about this. I continue to get confronted by some of the people from the communities that presented to our committee a couple of years ago, and I have to confess that I'm hearing a lot of frustration that they're not seeing a lot of the measures being implemented. And I do applaud you. There are some things that are progress. I think the 811 line, I think, is a positive thing. Certainly the improvements in lac La Biche to the dialysis unit, I think, is also a sign. But there's still some other areas. And let me start with rural ambulance and the use of non-emergency transfer vans. Has the use of non-emergency transfer vans, has that been expanded? How many non-emergency transfer vans are now being employed in the system, province-wide?
Yeah, and I think we did have a similar discussion around this same item last year. And the non-emergency transfer vans are contracted usually through AHS and through subsidiaries. So, so I will be happy to ask that question and report back. But I don't believe that we have that number top of hand, given that it's an AHS budget piece. But I do know that the number has gone up in the last year, and we'll be happy to share information with you on that.
What about rural ambulance and the dispatch and some of the rules regarding rural ambulance and the return to home base? Again, this is something, I'm sure you're hearing it because I heard a lot of it as well. Yeah. The concern about the borderless system and rural ambulance being pulled into larger urban centers and then being sort of trapped in an urban vortex, and they never get back to home base.
Well, definitely our goal is to make sure that we have ambulances available where they're most needed in Alberta. And I will tell you that my goal is to get them out of the emergency room as quickly as possible, because I think that whether you're in a downtown Edmonton emergency room, Calgary emergency room, or waiting in your local community hospital, no matter what, you sign up for that career because you want to get out there, you want to help people, you want to get them to where they need to go. So I think that sometimes frustration that people feel with being stuck in an emergency room becomes conflated with being away from home. No matter what, we know that we need to get trucks back on the streets faster. We're working with AHS on ways that we can continue to move that benchmark, but that is our ultimate goal. Okay.
So then another area that is a long time concern, and I know some adjustments have been made, and I know that there was a review done of RPAP, and that was extended, but that the mandate for RPAP has been expanded, which was one of the recommendations of our committee to a rural practitioner, action plan. I think that's very positive. I think it's critically important that we recognize that doctors aren't the only caregivers that can deliver services, especially in areas where it's been challenging to provide services. But one of the initiatives that was recommended in the rural health study, and I'd love to hear what's been done on this, and that is, I call it a grow your own program, and that's not has nothing to do with what you're thinking about, Mr. Clark. The grow your own program is about identifying high school and junior high school students who have aptitude for the healing arts. Sorry, it's not as interesting as you thought it would be. For aptitude for the healing arts, my argument for a long time has been if we spend a fraction of the amount of time identifying our next generation of nurses and doctors as we do identifying the next generation of hockey stars, we will have no trouble whatsoever staffing all of our needs in healthcare. So long preamble. What's been done about developing a homegrown program so that Alberta students become Alberta doctors, nurses, and health care professionals?
Yeah, thank you for the question and for the focus on other green shoots, which includes investing in these communities.
We'll get to that.
Not the type of green shoots that some members might be referring to.
We're 5 hours in, Minister. Keep plugging away.
Definitely this piece around ensuring that students feel attracted and excited about opportunities for a variety of career pathways in health. When you talk to students, they don't always know about the expanded opportunities that there are. They regularly think about doctors and nurses. They don't always think about all of the lab technologists, all of the x-ray technologists, all of the people working in medical device reprocessing who often can get training on the job. And those are absolutely fundamental for making sure that we have proper infection control in our local communities. I do want to also highlight that partnerships with the universities and with colleges to ensure that we have the right number of students coming into our programs and that they're being attracted to areas of focus where there will be opportunities in the province of Alberta is an ongoing struggle. Sometimes universities are training students in programs where we don't necessarily need that specific specialization. We might need more in other areas. So we continue to work with them on that, but it is not going to happen overnight.
Yeah, but that's a moving target, right? I guess on that topic, funding for the rural education, medical education programs at U of C and U of A, is that still being channeled through RPAP, or is it now going directly to the faculties in the two universities?
We've decided to move it directly.
Good. Good. I think that's a very positive move. And I think it recognizes that both of those medical faculties have had significant progress in terms of improving the number of A, general practitioners as opposed to specialists, and B, general practitioners who are choosing rural communities to start practicing in. And I think those are two positive developments. I think we have to continue along those lines, and I think they'll be very, very effective. And so that's, I think, the end of that segment. Thank you, Chair.
Thank you for your support in that. I really do appreciate it. And the other piece
Thank you. At this time, I would like to invite Dr. Starke from the third party opposition and the minister to speak for the next 10 minutes. Dr. Starke, are you wanting to combine your time?
No reason to change now. Thanks, Chair. Thank you, Minister. I want to just sort of bounce around a little bit. I think this will likely be our last segment to work together. So my first question just goes back to the performance objective that we were discussing about early childhood development and to support initiatives that foster maternal infant health. Is Alberta Health providing funding assistance to the Alberta Family Wellness Initiative?
I would have to confirm the rate of funding for that for you and get back to you about that specific grant. Yeah.
Okay. My second question on a different topic is a couple of years ago, the government instituted an insulin pump program for diabetes. I have a son who is a type 1 diabetic, and so certainly this is something that we've been sort of very supportive of. And one of the things that we talked about was decreasing the number of emergency admissions to unregulated diabetic patients. Have we seen that yet, is my first question. My second question, is the government looking to expanding the coverage specifically for glucose testing supplies? Because I know that for some diabetics, unfortunately, that becomes a barrier. These test strips are expensive. And, of course, if they're not testing as often as they should be, the risk of developing complications goes up because they aren't as well regulated. Their blood glucose is just simply not as well monitored.
Yeah, I'll start. And first, because I didn't get to share an anecdote last time, I'm going to do it this time. Thank you.
It's my 10 minutes. Go ahead. Chew it up.
Not that long ago, I was in the United States, and it was right after the bill to repeal and replace Obamacare had been stayed by the courts, or not stayed by the courts, stayed by other elected officials, and
they chickened out.
That too.
No.
And the server at the restaurant I was at was telling me about how he's a type 1 diabetic, that when he was on his parents' coverage, he had an insulin pump. When he went away to university and was no longer covered by his parents' plan, he didn't have a pump. He was taking the best guess he could, but he didn't have health insurance, and he was just hopeful that his sugars were within reason and that based on how he was feeling, he might try to eat an orange. which to me is so devastating. He did end up getting health coverage just a few years ago and proudly showed me his pump on his torso and said, you know, I was really worried last week that I wouldn't have it anymore. And
Well,
these are the kinds of stories that I think make Canadians so proud of the system that we do have.
Minister, on the one hand, no argument for me on that. On the flip side, though, my son's been on a pump for about the last 14 years. The supplies are really expensive and they aren't covered under a lot of health plans. And he's not on the pump program as of yet. He's working towards getting onto the pump program. So we're not there yet. I mean, we're working that direction. But both the cannulas and the supplies that are required for pump patients, as well as the testing supplies, run into the hundreds of dollars per month. So it is something that's still a concern.
Yeah, and I know that this is something that your government was grappling with in the lead up to the last election, and that there were some calls to see further reductions in access. And certainly this is something that we want to make sure in terms of wellness. I think it expands into this area as well. We obviously are in a difficult financial situation, as my colleagues in the chamber on the opposite side remind me regularly. We need to find ways to find savings, and I know there are other important areas for expanding investment. Sometimes maintaining the status quo is challenging enough when people are calling on you for deep cuts. So it's difficult.
I hear where you're coming from. That's the joy of being in government, Minister. That's why you knocked on all those doors.
Yeah.
So just moving on, but staying on the topic of diabetes, if you're like me, if you're an Albertan and you're proud of the research that's being done, you're familiar with the work of Dr. Shapiro and the Edmonton Protocol, and the fact that Dr. Shapiro feels he's actually very close to actually determining a cure for diabetes within the next 5 years. I'm just wondering, is there government funding either flowing through to DRIFCAN, to the Diabetes Research Institute Foundation for Canada, or other supports that are being provided? Because I think if we target the 100th anniversary of the discovery of insulin, which was by another Canadian doctor in 1921, by 2021, if we target the next 4 years to discover a cure for diabetes and have both of those developments happen within Canada, I think that'd be an incredible achievement.
Do you want to start?
I was just saying, I would agree, that would be incredible.
Maybe Dr. Amrine might want to respond.
Michelle Evans is our Assistant Deputy Minister that's responsible for a lot of this activity. If my answer is inadequate, we can call Michelle to the microphone. My understanding of the islet cell transplant program is that the government of Alberta does cover the transplantation costs. The challenge that Dr. Shapiro seems to be having, and we're doing what we can to help him alleviate this challenge, is that he's looking for reciprocity across Canada, and each province gets to decide on their own whether it's experimental or routine. There are some provinces that decline to list this, and until we have all provinces listed, it's a financial co-payment thing. So I think that's his struggle. Otherwise, he receives funding from a number of sources, including foundations, but as well from the health system.
Yeah, if we could find out what funding his specific research is receiving, or if it's receiving any funding through either the Heritage Medical Research Foundation or that I just appreciate that. I think the work that he's doing is incredibly exciting and has incredible potential, not just for Alberta but worldwide.
Yeah. We will report back on the sources of his funding.
Thank you. Minister, if we now look to page 121 in the government's fiscal plan, that's the page that has the breakdown of all the full-time equivalents. And I note there's been no change in the number of full-time equivalents in the health department itself, and I congratulate you for holding sort of the line there. There is an increase in 1,500 full-time equivalents in AHS. And you know, you need people to deliver services. I absolutely acknowledge that. But it just, there's a big number, 1,500, and then it says home care, continuing care, primary care network, but there's no breakdown whatsoever. Would it be possible to get a breakdown from AHS? I'd sure like to know how that 1,500 breaks down. I guess I'm a little puzzled by primary care network being there. Primary care networks, I thought, were funded through the capitation formula, and I didn't think that they were actually employees of AHS.
In terms of supporting subsidiaries, primary care networks and foundations, there's 100 that are aligned to that through that
Okay.
line item. So it's through some partnership work that's being done there. The change in full-time equivalents was required to address the health system priorities, as you've mentioned, including to community-based care
Right,
with expansion in areas including home care. So the new FTEs will be 900 in clinical staff and 600 in clinical support staff. So that would be other types of people working in the healthcare system to support those clinical staff.
Okay. And when you have an opportunity, Minister, maybe if you could get me the breakdown, because between home care, continuing care, and because that breakdown you've just given me is a little bit different from the reasons that are listed here on page 121.
Yep, and the one thing I'd just like to add is that the 450 FTEs are, 450 of those FTEs under clinical staff and clinical support staff are around the new continuing care beds that are going to be coming online as well.
Okay.
So supporting home care activities, 650 full-time equivalents, and then I mentioned the 100 for PCNs.
Great. Minister, on a topic that you're certainly familiar with and is a close-to-home topic for me, and that is with regards to extended care in Lloydminster. The Dr. Cook Extended Care Centre, we had a brief exchange and question period about this a couple of weeks ago. Where are things with the consultation with the community? I know Dr. Amrine was in Lloydminster last October and met with some officials, but I know that there is still an expectation and people are still awaiting an opportunity to have that conversation with regards to the future of the existing Dr. Cook nursing home.
So in one of our trio meetings, I think we call them, between AHS, the department, and myself. I think actually Quartet, because the board chair is there for AHS as well. We were discussing my expectation around there to be consultation and some type of engagement with the community. So I asked that both the department and AHS work on developing a strategy and bring it back so that we can consider that. So it's in the works, and we'll be happy to involve you in those discussions.
Just going to say, loop me into it and you can save yourself a lot of grief.
We want to loop you into it, and I agree.
Yeah, no, that'll help. Minister, thank you very much. I think we're pretty much done.
Oh, slick.
Well, we have about 1 minute left on the clock. Dr. Starke, if you would like, I would like to invite you and the minister to speak for the remainder.
Sure, why not? Sorry?
Tell the Tommy Douglas story.
Oh, no, it's much it's much longer than a minute, but it is a good one. Minister, your budget last year represented, the budget you had approved last year represented about a 3% increase, sorry, a 1.8% increase over the actual for 2015-16. But as we know, there's been nearly $400 million of additional expenditure in your department. This year, you're forecasting a modest increase of 3.3%, but I guess my question to wrap up, how confident are you that you're going to be able to meet the $21.4 billion budget objective that you've set for this year?
Thank you very much for the question. I think that this year's target is within reach. I think that last year we were incredibly aggressive, and we did need to have supplementary supply.
Thank you.